At ESC 2020, from the REDUCE-IT team, we presented a number of different analyses. One analysis pertained to the statin at baseline, and we examined the different statins. Also, we bunched them by type of statin, hydrophilic or hydrophobic. And from a bottom line perspective, there was a consistent benefit of icosapent ethyl versus placebo across all the different types of statins at baseline. And I would say importantly, if one were looking, say, at atorvastatin or rosuvastatin, the most potent statins, there as well, there was benefit that was consistent as in the overall trial. And not that one should really look at p-values in individual subgroups. Trials aren't designed or powered for that. It really is more appropriate to look at consistency. But even if one goes to that level of looking at actual significance, it was significant even in patients on potent statins. So this form of therapy, icosapent ethyl, is definitely incremental to statin therapy, and it's definitely incremental to potent statin therapy. So even if patients are getting high doses of atorvastatin or rosuvastatin, there's still substantial benefit of icosapent ethyl added on board. Furthermore, we grouped the statins by whether they were hydrophilic or hydrophobic, and so no difference between the two with respect to the degree of benefit of icosapent ethyl versus placebo. And the reason to do this was just that some folks have raised questions about the mineral oil placebo. And if that were really at play, then one might expect to see some sort of differential effect between hydrophilic or hydrophobic statins. It's all really a lot of conjectural nonsense, I think, to be honest, but there were some theories out there about statin malabsorption. And if that were the case, obviously it would be different for hydrophilic and hydrophobic, and we didn't see any evidence of that type of interaction. So I think we can be quite confident that the placebo here is a placebo, as one would normally expect in randomized double-blind placebo-controlled trials. But again, for me, the more important message is just that even with potent statins on board, icosapent ethyl still handily beats placebo. Another analysis that was presented at ESC 2020 from REDUCE-IT pertained to the baseline LDL tertile. And the purpose of this analysis was to see if even in patients with low baseline levels of LDL cholesterol at the time of randomization, there was still significant benefit to being randomized to icosapent ethyl versus placebo. And indeed, there was. That is, there was a consistent benefit across all three tertiles of baseline LDL cholesterol. That was true for first ischemic events, for total events, for the primary endpoint, for the key secondary endpoint. And once more, in these subgroup analyses, really the right way to look is for consistency and seeing if it just sort of makes sense and looks to be a consistent benefit. And indeed, that was the case. I don't think it's appropriate really to get into subgroups and p-values and look for statistical significance. That's a rather high hurdle to clear. Having said that, if one does go that step, which I don't think really is statistically warranted, but if one does, as it turns out, even in the lowest tertile, there was a significant benefit. So it really shows just how robust the overall trial results are, that we can even get statistical significance once we're looking at subgroups such as this one. But the more important message here really is that even if one is achieving low LDL levels with contemporary therapies, there's still significant incremental benefit of icosapent ethyl versus placebo. So go ahead, do what you want to in real practice. Use a high intensity statin in high risk patients, and if they tolerate it, great. Add ezetimibe if you want. Add a PCSK9 inhibitor if you can. But even if you're doing all those things and blast the LDL to really low levels, there's still a benefit of this novel therapeutic approach of the EPA axis using icosapent ethyl. There was an additional analysis from REDUCE-IT presented at ESC 2020 by Dr. Brian Olshansky. He was the chair of our data safety monitoring board for REDUCE-IT, and what he presented was an analysis of the interim results of REDUCE-IT. Of course, everyone knows the final results of REDUCE-IT. We published that in the New England Journal of Medicine. But during the course of the trial, the data safety monitoring board is obviously monitoring safety of the drug, and they found the drug to be very safe and didn't tell us to stop the trial, of course, and overall just concluded that the drug was very well tolerated and very safe. But they also did 2 pre-specified interim efficacy analyses. And what happened was that now that we've gone back in time to look at those data, of course the DSMB knew those data, but now that as a steering committee, we've gone back and looked at all the data there, we see that at the first interim analysis, as well as the second interim analysis, the trial was already quite robustly positive. And what this tells us in terms of new knowledge is that the benefits that have accrued from icosapent ethyl in the REDUCE-IT trial really kicked in much earlier than we appreciated, such that by that first interim analysis, there was already marked statistical significance of both the primary and key secondary endpoints, and certainly by the second interim analysis. And of course, the final analysis was very, very robustly positive. So I think this is important information that illustrates how quickly the benefits of icosapent ethyl kicked in REDUCE-IT. There's also some other interesting aspects in terms of data safety monitoring boards. You know, at what point should they stop trials? At what point should they continue trials? And here our data safety monitoring board, even though they felt that the drug was already quite effective early on, appropriately felt that continuing the trial was the right thing to do to gain as much information as possible about keeping patients on the drug long-term, safety of long-term use, further incremental efficacy of longer-term use, and also to give us the ability to look into various subgroups and secondary and tertiary endpoints. So I think they made the right decision. In fact, most times when DSMBs stop trials early for efficacy, they end up getting criticized. I can't actually think of one time where they haven't been criticized by at least somebody for stopping a trial early. So I'm glad that this independent DSMB did take the trial to the end, but we do learn now that the trial was in fact very positive earlier on.